So choosing your constraint in revision total knee is a very important part. In other words, more than the philosophy of the bone substitution. Overview, I'm going to talk in these headings: introduction, definition of constraint, instability post-total knee and the need for using constraints, type of constraint implants, treatment options for instability, algorithm for deciding level of constraint, case scenarios, take-home message. And basically, it's a global increase in joint replacement surgery and significant improvements in prosthetic design, better understanding of knee kinematics. Projections indicate a dramatic increase in demand for knee arthroplasty over the next 20 years. Estimated increase of 280% for knee replacement, of course, in American statistics. But even in India, you all know that the amount of people attending the conferences coming at 7:30 to the master class show that there is a lot of traction. Since Ashok was doing his first surgery in Delhi. When was that? Which year was that, Ashok?
87.
87, yeah. We've come a long way. So what is the burden of revision total knee? I think it is going to be 600% from 2005 to 2030. Again, the numbers are from America. We will not have that much burden, but definitely revision burden is going to increase. Because the more primary surgeries, the more revision surgery. It's a simple logic. Now let us say, what is a constraint in knee arthroplasty? It is the effect of the elements of the knee implant design that provide the stability needed in the presence of a deficient soft tissue envelope. In fact, soft tissue envelope is the biggest constraint and biggest holding of the stability. When it is not there, we have to look the alternatives. So instability in revision total knee, it is basically a laxity or instability may be the result of, number one, generalized soft tissue laxity. Sometimes we see in recurvatum knees, and inadequate flexion extension gap balancing, and improper component position or malalignment, and ligamentous insufficiency. To address these, implants with varying degrees of constraint are available. So with higher constraint, increased stress is transmitted to the modular implant host interface. This will carry to implant loosening and ultimately to failure. So obviously, it is a fundamental principle to use the least amount of implant constraint necessary to achieve a satisfactory result. So you just cannot put a hinge on a primary knee. So types of constraint implants, you all know that. First of all, it's a PCL cruciate retaining knee, then PCL substituting knee, and then a deep dish knee, then a VVC, varus valgus constraint, and then a linked hinge. So this is the constraint ladder which is available to us. So now let us go to one by one. PCL substituting, it is a PCL sacrifice here, and there is a posterior stabilized one. It have a tibial post and femoral cam. I think majority of the young surgeons do this, and Ashok is the only high volume surgeon who does CR even in the revision scenarios. And anterior stabilized or deep dish ultra congruent designs, highly conforming tibial inserts to increase the stability. This is my favorite. If you ask me what is the best implant design, I will say deep dish and ultra congruent. That will have the best of the both worlds. Now coming to the next ladder of the constraint, that is varus valgus constraint, and examples TC3 in Zimmer, Depew, LCCK in Zimmer, and NextGen, etc. Basically, they have got a very tall, often reinforced tibial post and a deep femoral box, and it will provide more inherent coronal plane stability than PS process. So obviously, the constraint is more, the stability is more. That is a diagrammatic representation. You can see that the standard TK post is not engaging as much as the other one. So it gives medial lateral stability and it acts as an internal splint. And if you see this picture also, you can see that the jump height is increased in the VVC constraint. So the dislocation is less. And again, varus valgus constraint and even a internal external rotation constraint also is there to some extent. So there are some of the papers available here. If you have any laxity or instability during revision, varus valgus constraint is a great option. So never hesitate to that. As I said, the fundamental principle is to go for the least constraint in a primary or a complex scenario. But when it comes to the revision, the entirely it's a different ball game. You just cannot put a single or lower constraint and hope for the best. So these are the things which will make your decision making easy. So outcomes of VVC implants are comparable to the use of lower constraint during revision. That's a big relief, because initially you were a bit skeptical to use the VVCs, but now you can see any doubt about the insufficiency or the adequacy of the collateral ligaments, you can go and put the VVC. Provides additional security against instability after the revision totally. And now the next constraint in the ladder is linked hinge, which is a modular or rotating. Highly constrained devices, the tibial and femoral components are linked with an axle To decrease the overall amount of constraint, these components permit a rotation of the tibial bearing around a yoke on the tibial platform. When I started the practice in the first around 30 years back, the link was the hinge was a no-no. But after fourth generation hinges come, all the literature about the bad results are about the first generation hinge. But now the hinges are very, very amenable for surgeries, not as endoclinic does, but there are many instances where you can be bailed out by hinge, and the results are pretty good in the fourth generation, especially rotating hinges. Now let us say what are the indications in the revision totally for the varus valgus constraint. The collateral ligament laxity, mild to moderate flexion extension gap mismatch, underline. A lot of the times in FFDs you come across this scenario. Mid-flexion laxity, where is the elevated joint line, and revision for prosthetic joint infection, two-stage or instability. So these are the treatment options for instability. So basically it's a very self-explanatory. Option isolated poly exchange, prerequisite proper alignment and stable flexion of both components should be there. Then you can go for this one. These are the instability in flexion, extension, thicker poly implanted, PCL insufficiency and PCL retaining knee, deep dish poly can be used. That is the simplest one. Next, single component revision. What is the prerequisite? Proper alignment and stable fixation of retained modular component should be there. And these are the indications which are very self-explanatory. Now let us go to the full component revision. Again, collaterals not completely disrupted, underline. And the indications are mal-aligned, unstable components, and inadequate constraint option is existing implant. Now last ladder is the injury arthroplasty, completely disrupted collaterals. If the collaterals are gone, hinge is the only option. Don't try to put anything else other than hinge. Severe bone loss, severe flexion extension gap mismatch. So it's an algorithm which is much easier to understand. So you come from PCL retaining, rarely used, but except Ashok, intact ligaments, type 1 AORI defects. And PCL substituting intact collateral ligaments, type 1 AORI. AORI already Hemant has alluded to that. And then go to the VVAC, the next step in the ladder, insufficient collateral ligament and type 2 AORI defects. And then go to the hinged knee, absent and disrupted ligaments, type 2 by 3 AORI, and mega process obviously periprosthetic fracture type 3 or severe bone defect and loss of condyles. So that is the algorithm there. So know your implant. These are all basically, not all constraint is created equal. So it is a thing which you should have it in your armatorium. Any knee surgeon should know all the implants available. First of all, teach yourself, get hold of all the implants available in India. But that's important, not in the abroad. So then only your choices are made properly, not on the day of the surgery. Now, typical hinge indications: MCL deficiency, recurvatum, neuropathic joint, underline, extensor mechanical deficiency, and DFR. And instability leading cause of re-revision. Revision endpoint probably underestimates the problem of instability. Multiple studies have associated the use of the VVC with reduced risk of re-revision. Basically, varus valgus constraint implant is the workhorse of the most of the revision scenarios. Let us go to the case scenarios. A 55-year-old female, 10-year post-UKR, right knee pain for the last 1 year, intraoperative findings, lateral compartment OA, and implants not too loose, but the opposite compartment is arthritic. So you have to revise that. So the revision performed with the PS constraint here, and ensure adequate process fixation based on 3-zone concept, as alluded already. Final implant, distal femoral augment and tibia wedge with rod. No need of increasing the constraint here. Now case scenario 2, 70 years old male, 4 years post-op TKR, complaints of instability, history of fall. I used to do a lot of CRs. If the CR after some time, if it goes to instability or coming with repeated effusions, that means the cruciate has gone, the PCL has gone, and now it is a new scenario. You just go down there and see, you can hear lax MCL, and there is a moderate bone loss also. And then we went and put the VVC with extension stems. Case scenario 3, 16-year-old female, and this is again a CR implant, and 6 months post-op, fall at home, and compromised MCL, and obviously intraop findings are instability persisting with TC3. I tried with TC3 here. It doesn't hurt to try it, but if it is not there, you have to go for the hinge process. So I changed the courses and went for the hinge process. So this is the final implant. So recent advances, now robotics have come, off-label use for revision totally, objective assessment of ligament laxity and trailing, Basically, it's an interesting concept to optimize the component positioning and ligament stability. We are just started doing this one. Basically, we retain the old implants and register on the top of the implants, and that will give something in the future. China, there is one or two surgeons, they are doing a lot of things here. So probably robotics will help us in the future. So take home message, critically assess stability in all planes during pre-op and intra-op. In most revision scenarios, VVC implant or hinge implants are necessary. In a small subset of patients, you will still achieve excellent stability with the PS designs. Do not compromise stability over concerns of longevity. Important and take-home message. Thank you so much. With proper 3-zone fixation, especially metaphyseal with sleeves, constraint implants have excellent durability. When in doubt, always use mid-level constraint, that is varus valgus constraint implants. Thank you.